welcome everybody who attended this special ESB online sessions. So I have a couple of slides. I don't want to steal the time from the others, but I'm Enrico Dall'Ara from the University of Sheffield and the Insigne Institute for In Silico Medicine, and together with the student committee, we have organized this sessions and the ESB Council, of course, and we are using a new platform. So bear with us. We hope that we have only a few or hopefully none technical issues. And today we have actually 2-hour session. The first one is with the Student Award, and the second one is on the Clinical Biomechanics Award. We have 4 speakers for each. And tomorrow we have another session with the presentation from the winner of the Best Doctoral Thesis Award. And then we have some special announcements from the council to give you some more information about who will be the new council members, about the awards and so on. So don't forget that you need to register also to that special session, and you should have received 2 links, 2 registration links, one for this webinar and one for the one tomorrow. So don't forget that you have to register for them as well. So today we have, as I said, 2 awards, 4 presenters for each award. They have 10 minutes presentation each, plus 5 minutes questions. So if we want to answer questions, please use in the control panel the Windows session, and there in the control panel you have the question window, and then you can ask to the organizers a question. The moderators then will pick up from that list some questions to ask to the presenters. And the other thing that I should mention is that the sessions will be recorded and they will be put in our YouTube channel. So make sure that you can also share. We will share also these links later on. So it seems that you don't see my presentation. So have you seen my slides so far? Luca, can you tell me?
I see them only now. They didn't come up earlier. I see them now.
All right. So there's not much, but basically the important things, it was just an overview of the 2 sessions, but I already mentioned all the information that were required. And only the notes that I would like to stress are that the session will be recorded. You can post your questions using the question window in the control panel, and that you should register also for tomorrow's special session using the links that you have received. So again, I would like to thank all the student committee who have tested the new system, and it is a big trial for us, so fingers crossed that things will go smoothly. I will now make Luca as a presenter, so I know that you have a couple of slides to show as well. So now you should be able to share your screen or window.
So now you should be seeing my PowerPoint.
Yes.
Correct? Yeah, okay. So first of all, I would like to thank Enrico and all the student committee for setting up this webinar system, which is, I guess, quite demanding to arrange, and I hope everything will run smoothly. Of course, we all would like to meet in person, shake hands and drink coffees together, but given the circumstances, it is already a success that we can virtually meet, and we insisted on having this virtual award session because we still believe it is important both to have our July meeting, like every year we have a Congress, and also to give these awards to the most deserving colleagues of our society. The first award that we have today, starting right now, is the Student Award, which was created more than 20 years ago to acknowledge scientific excellence in quite young scientists of our ESB. We are having one first prize and 3 runner-ups selected by the work of the award committee, and I would like to thank all the colleagues who spent all the time in reviewing the papers and making a selection. So the winner will be rich. He will get €1,000, and the runner-ups also will have some money to celebrate with their €400, mostly donated by Elsevier. Just to give an idea, this year we had 62 applications. First, they were scrutinized by the Congress abstract reviewers when we still believed we were going to have the real Congress in Milan. A short list was prepared, and the Student Award Committee, consisting of 10 colleagues, made a selection, and therefore we had 4 finalists, which we'll be talking today. And this is the list of the 4 finalists presenting in alphabetical order. So the first speaker will be Pouyan Asgharzadeh. I hope I pronounced your name in a reasonable way. You can start already your presentation when you're ready. And as Enrico said, if anybody in the audience has questions, you can type them in the chat window and the moderators will handle them.
Should I start now? Okay, then I will start. Thank you, Luca, for the kind introduction, and also thank you, Enrico, and all the organizers. I would like to welcome everyone to my talk today and this virtual session of ESB. My talk is about deep learning analysis of bonus structure in osteogenesis imperfecta using HRPQCT images. So to give you an introduction of the OI disease, it's a genetic disease that affects bone and mostly affects collagen type 1, and it's also known as brittle bone disease. The symptoms of this disease vary based on the OI type, but it includes increased fragility, long bone, and spine deformities, as what you can see here in these pictures of patients with OI. So, it's important to know that at this point there is no cure for OI, and the treatment includes physical therapy, and in case of fracture or deformity treatment, basically the treatment is with bisphosphonate or through surgery. And at this point, monitoring and planning treatment is through calculating and measuring BMD, but it has been proven that this is quite inadequate to cover the heterogeneity that is observed in bones of OI patients. It's also very important to know that decreasing the fracture frequency in OI patients increase their life quality quite drastically. But this heterogeneity in OI makes it very important to have patient-specific bone strength model that would allow having treatment, patient-specific treatment regimens. Recently, HRPQCT imaging modality has provided researchers with quite high resolution and detailed view of the bone structure, and it also allows to perform micro-FE estimated strength estimation of the bone strength that has been shown that correlates quite well to fracture possibility. And actually, one of the talks in the next session would address this point specifically. Machine learning models that have gained quite some momentum recently have been able to be shown that they are able to automatically correlate bone structure to its functionality and develop image-based analysis of bone mechanoresponse. Therefore, the goal of this study was to combine computational imaging, micro-FE analysis, and machine learning to create patient-specific bone strength maps, which allow us to identify strength influencing factors in patients, in OI patients, and predict treatment effects for each patient specifically and move toward patient-specific treatment planning. In this study, we used HRPQCT images. We acquired HRPQCT images of 91 adult patients, male and female, with OI type 1, 3, and 4. These images has been acquired across 12 different hospitals across the world. And a subgroup of our patients underwent a treatment with cellular neutralizing antibody, where we wanted to see if our model can predict treatment effects. And so we did a follow-up scan after 12 months on these patients. For each of the patients, we calculated a series of parameters from the HRP-QCT scans, which I'm going to call features from this point, including features describing bone material, bone region, trabecular and cortical microarchitecture, and also features describing demographic and imaging modality. So as I said, we performed a microfee analysis to have an estimation of the bone strength by simulating a uniaxial compression setup. And then afterwards, by using Pistorius failure criteria, we calculated the failure load for the radius bone that we had here. And as you can see here, this is the setup that we had, and basically the sample of one of the patients, the distribution of the strain, and the distribution of the failure load in our cohort. We determined the correlation between all of the features that I showed in the previous slide to the failure load, and we saw that it certainly exists, a certain correlation between these parameters and the failure load, but this correlation is quite complex. Therefore, we would need to develop a model that can understand and handle this level of complexity of correlation. We created a deep neural network to basically map or predict results of the microFE simulations, here being the failure load, directly from HRP-QCT images. And to do that, we first went through some pre-processing steps, and we increased the training data to cover for all of the imaging variances. And as you can see here, this is the architecture of our network, where slices of HRP-QCT are as input, and then the network would automatically extract the structural features and correlate them to one specific failure load and predict the failure load from the image directly. We can see here when we compare the results of predictions of the model to the simulation results, we see that the model is predicting with quite high accuracy the results of the simulations. And as the next step, we want to now understand the correspondence between the bone features and bone strength. Therefore, we develop an unregulated data mapping machine learning model. So what this model does is that we first would combine all of the features coming from each of our patients, whether in terms of demographic features, imaging modality, and all the features describing bone structure. And we will train a machine learning model that would, purely based on these features, predict bone failure load. And then that would tell us for each patient specifically how much each parameter is influencing the bone strength, and that would allow us to move toward a data-driven treatment plan. So we chose gradient boosting regression series of models, where we designed a model FX to predict the bone strength S from all of the bone features. These kind of machine learning models are based on decision trees, where multiple decision trees are trained in a consecutive manner, where each new tree would focus on the data sets that are introducing highest amount of error. And then at the end, in a linear combination and in a stage-wise manner, we combine all of the decision trees together to make our gradient boosting regression model. The model that we trained could quite nicely predict the failure load, as you can see here, with an R-score of 96. And we could see maybe the most important thing for us was that when we looked at the parameters and the importance of each of these features in our predicting model, we could see that 3 of our features, namely total BMC, cortical area, and cortical BMC, which are correlating quite nicely to the mechanical characteristics of the bone, are distinctively the most important features for our model to make this prediction. Therefore, in the next step, we decided to create a reduced model only based on these 3 parameters to predict the failure load. As you can see here, when we compare the failure load predictions to what comes from the simulations, our model reaches quite comparable accuracy in prediction. But now with this reduced model, what we can do is that we can look at the marginal effects on how in our cohort, how changes in these parameters result in changing in the failure load. For example, we can see that cortical BMC and total BMC have quite a linear, simple relationship with the failure load. But when it comes to the cortical area, the relationship becomes much complicated. With this at hand, and with the model that we trained here for the first time, we can now create a 4D failure load map with 3 parameters as input. As I said before, cortical area, total BMC, and cortical BMC, and the color code that you can see here as our failure load map. That this covers now all of our cohort, and our patients will sit inside this map. Having such a map allows us to go and create patient-specific points. So this gray point is one patient where we find it inside our space. And for each of the patients now we can extract 2D maps, biparametric failure load maps, that we can actually place our patients on these maps. These are the white dots, and the gray dot is the average patient. And we can move towards now predicting, first of all, understanding for each patient what would be the ideal scenario in change of terms and changes of these parameters for better failure load. But also we can look at the prediction of the treatment effects. These are shown here with crosses, and we can see that our model can, with a comparable accuracy, predict after 12 months, based on the changes on these parameters, the failure load. How would it change? So this failure load map would allow us to have actually a patient-specific model describing bone strength and predicting treatment effect. So to conclude, we have created a model that predicts bone strength for a heterogeneous OI cohort directly from HRPT-CT images. And we showed that with 3 parameters, you can create a reduced model and predict the failure load. And we showed that such a reduction in dimensionality, we can create then a 4D failure load map that allows monitoring patient-specific treatment effects and moving toward designing a defective patient-specific treatment plan. For the outlook, we will now be able to see what is the dynamics between different features and the failure load in a load-carrying bone, such as tibia. We will be able to further train our model to make it somehow more knowledgeable based on training on cohorts of osteoporosis or other diseases. And we can, and for the final goal of having a patient-specific treatment plan, we could move towards training on different variations of dosage or duration for our treatment to provide the physicians with the best outcome of each treatment. So with this, I would like to thank you all for your attention, and all of the collaborators from Uni Stuttgart, McGill, and Shriners Hospital, and the funding sources.
Thank you very much, Pouyan. Very nice presentation, very well on time. So I remind the audience that if they want to have to ask a question to the speakers, you can use the questions window within the GoToWebinar control panel. This will go directly to the moderators. While I don't see any question at the moment, so I can kick off with a couple. It seems that so your best, so the features that best predict the bone strength are so the total BMC, the cortical BMC, and the total area, which may be linked and related to each other. So they may not be independent parameters. So have you accounted for that, or can you comment on that?
Yeah, that's absolutely correct. So I'm going to go back to the slides. So here, in these slides, when we look at the how these parameters affect the failure load, these are by assuming that the other parameters are constant and only one parameter changes. But as you said, these parameters are interconnected to each other. Therefore, when we go and when we create such a failure load map, this is such a map would theoretically also consider for all of the relationship that these different parameters have with each other. So I absolutely agree that these parameters are connected to each other, and I think that creating such a map for one patient specifically would allow us to look at how different parameters change at the same time for each patient to therefore account for this relationship between different parameters.
Yeah, thank you. So there is a question. I just read the question. Your model seems to be trained based on microFE simulated data only. Should you not compare to experimental data? And if not, your model will never be better than the microFE models. So
yeah, that's absolutely true. And of course, that this model can learn what as good as the microFE simulation is, and this is what we focused at this point. And understanding the limits of the microFE simulations is, of course, something that needs to be carried on. But as far as I know, microFE simulation at this point is one of the best things that one can have for an approximation of the fracture possibility. For example, if you go and if you compare it to BMD measurements, microFE has shown way better correlation to the fracture possibility, and this is what we want to go towards. But another aspect of such a model is basically this is a plug and play model. You can basically, if there comes a better approximation as the failure load from the micrography analysis, you can just plug it in, train on that data, and theoretically, it would be possible to perform the same analysis.
Okay, thank you very much. I have, well, I'm just cautious of time, so there's time only for one more. So we're just still related to the validation. So another question is, was the validation, a cross-validation on a training set or a completely independent validation?
Yeah, so we did what I didn't show it so far because of the time limitations, of course, but what we did was that we separated the data set into 80% training, 20% test set, and then in the training data set, we did a 5-fold cross-validation, which at each step, the training set would be considered into training and validation. And at the end, after the training, across all of the folds, we tested, so all of the results that you saw was the results on the test data set that was not used during training at all.
All right, great. Thanks a lot, Pouyan. I think that I'm a big question of time, so we can move to the next speaker. And thanks a lot for the presentation and the discussion.
Thank you.
Yeah, thank you for your presentation. And so I can introduce the next speaker, Jorge Barrasa-Fano. He is going to present his paper about novel and accessible 3D traction force microscopy applied to an in vitro vascular disease model.
Okay, so hello everyone. Thank you very much for attending my talk. And also thank you for the organizers for giving me this opportunity. I'm Jorge Barrasa-Fano, and I'm going to present my work called Novel and Accessible 3D Traction Force Microscopy Applied to an In Vitro Vascular Disease Model. Now, the first thing that I wanted to do is to convince you about the importance of cell mechanics. You can see here in the video on the left, the embryonic development of a zebrafish. And it's pretty amazing how all of these cellular movements, massive cellular movements, completely change the shape of an initial egg into a very, very complex body. So obviously, there's a lot of cell mechanics and cellular forces involved in this process. And now on the right of the slide, you see an in vitro model of metastatic cancer. And you can see how the cells on the edge of the tumor, the cells are depicted in green, start migrating away from the tumor by applying tensile forces on the surrounding collagen fibers. So these are just two examples, but it's pretty clear that cell mechanics do play an important role in many biological processes. So we can ask ourselves the question, how do we measure cellular forces? Luckily, there's a way, and it's called traction force microscopy, and I'm going to briefly explain it in this slide. So in an in vitro model, you can have some cells seated on top of a substrate. And the substrate normally has embedded fiduciary markers that typically are fluorescent beads. And cells are able to form focal adhesions, and through stress fibers, they apply force on the substrate, deforming it, and therefore displacing those beads. Now, we can take an image of this situation, and we call this the stress state. And then we can remove the cell or block its mechanical interactions and take another image that we call the relaxed state. Now we can compare these two images, and with image processing algorithms, we can measure a displacement field. And if we know the mechanical properties of the material, we can compute a traction field. Now, we can make this a little bit more biologically relevant by embedding the cells in hydrogel, and we call this 3D traction force microscopy. But of course, things here become a little bit more complicated. And especially for me, because well, as an engineer, I care about accuracy. So there's two main factors that heavily affect the accuracy of traction force microscopy. One of them is the bead density, so the number of these points here that we have to measure the displacement field. And the other one is the focal adhesion size. Again, focal adhesions are areas where cellular forces are applied. So the interplay between these two factors have a heavy effect on the accuracy of traction force microscopy. And as a result, the displacement field is inherently noisy. So if we compute directly the traction field from that noisy displacement field, the traction field could be physically inconsistent. So these are the main challenges that we wanted to tackle in the first part of this study. And the first thing that we did is to develop a new traction recovery method in collaboration with Professor José Antonio Sanz from the University of Sevilla. And we developed it in a nonlinear elasticity finite elements framework. And this method has two main ideas. The first one is that we look for an alternative displacement field that's similar to the one that we measure, but we apply certain regularization. Now, in state of the art, regularization is typically, the regularization that's typically used is Tikhonov regularization, but here we impose a constraint that has a physical meaning. So we want to fulfill the equilibrium of forces in the hydrogel just because that's a physical law. So we can write this in mathematical terms, and it's just solving a minimization problem with a certain constraint. And we can solve this analytically. And after some matrix algebra, it turns down to solving this system of equations that's relatively easy to solve and can be done in an efficient way. And once we solve it, we have this alternative displacement field from which we can compute more reliable tractions because we know that those will be physically consistent. So then the next step was to validate this method in an in silico simulation framework. And we wanted to do it in a refined manner. And so we wanted to include as many realistic conditions as possible. So we did this by acquiring real data from an in vitro model of angiogenesis and acquiring images by means of confocal microscopy. And I will come back to this in vitro model a little bit later, just follow me for now. But what we did is we segmented a cellular structure and we did a finite element mesh of that geometry. And in Abacus, we generated ground truth displacements and tractions, but incorporating those inherent challenges that I mentioned before. Namely, we played around with different focal adhesion sizes and different bit densities. So the number of points that we have available here in the microscopy images. Now, as a result, our method proved to be more accurate in retrieving the ground truth traction patterns compared to a method that didn't use any regularization at all. And down here in the bottom of the slide, you have a quantitative assessment of the errors, and you can see that both methods perform better with increasing bit density. But more interestingly, both methods have a harder time in retrieving tractions produced by focal adhesions that are small and sparse. However, our method proved to be more robust in general against all of these inherent limitations compared to the other method, which made us happy, of course, because again, we're engineers and we care about accuracy, but all of these things that I've told so far are completely useless if I am the only one using this method. So the next thing that we did was to create a MATLAB toolbox that we call TFM Lab, and it includes not only our method, but also all the other computational steps necessary for traction force microscopy, including displacement calculation, automatic finite element meshing, and so on and so forth. The interaction between the user and the software are quite eased with the use of graphical user interfaces for every step. There is no need for manipulating any code. And an experienced user can analyze in 1 hour up to 4 full 3D traction force microscopy cases. And just to give you an idea, in my group, it would take the same amount of time to analyze just one image, and not even including all the steps that I'm showing here. So it's quite an achievement. So now the next step was to use all of these things in actually something that has a biological meaning. And here's where we use that in vitro model of angiogenesis that I mentioned before. Angiogenesis is the growth of blood vessels from pre-existing ones. And we recently published this in vitro model that allows us to see the initial state of growth of blood vessels. And this in vitro model also allows us to apply our traction force microscopy workflows. In this work, we used polyethyl glycol hydrogels with embedded fluorescent beads and human umbilical vein endothelial cells that formed these angiogenic sprouts. Then we used our software to retrieve displacements and tractions around those angiogenic sprouts. And then we joined our forces with an institute in Grenoble to study a particular vascular disease called cerebral cavernous malformations. This disease is related to a specific mutation of a gene called CCM, and it causes vascular lesions in the brain, similar to those encountered in tumor blood vessels. And the purpose of this study was to investigate what's the consequence in terms of force generation of endothelial cells of this mutation. Now, this is still work in progress, but what we're already seeing is that CCM depleted cells, so cells that have undergone that mutation, show an increased force generation compared to control cells. So these cells here on the right haven't undergone that mutation, and you can see that these ones over here have slightly higher displacements and tractions. So again, we have to verify this with more statistically relevant number of samples, but if we do so, it would be a little step further in unraveling mechanisms involved in a vascular disease by means of traction force microscopy, and therefore validating its usefulness in a way. So in summary, in this work, we have developed a new traction recovery method for 3D that then we validated with in silico simulations, including realistic conditions, proving its accuracy. And then we included it in an accessible MATLAB toolbox. And finally, this is ongoing work, but we're applying it to an in vitro model of a specific disease. So that was it. I would like to thank my co-authors here in bold, and also the rest of my research group, because they also contributed in a way to my progress, and also the funding institutions. Thank you very much for your attention, and I'll be now happy to answer any questions.
Thank you very much, Jorge. So it was, again, a very nice presentation and on time. As usual, please post your questions in the questions window. I'm starting with one. With your approach, you're adding a regularization step. And usually that also implies a smoothing in your displacement field. And when you have evaluated the errors in your field, have you looked also at the error heterogeneously in the field? So if it was higher in one region where you would have expected higher displacement compared to another region where the displacement were low?
Mm-hmm. The error metrics that I showed are not considering, or we didn't look at which specific regions are more error prone, but this smoothing parameter or this regularization parameter is different to, for example, the smoothing parameter used in Tikhonov regularization, because that really depends on what value you give to that parameter. If you give it a higher value, you will smooth more, and vice versa. But this parameter, we just solve it analytically, so we don't give any value to it. It's also part of our solution. So we compute the analytical minimum of that function. So it's not depending.
Yeah, which in your optimization process you can do, but whenever you have to do a measurement where you don't know the answer, you don't know what would be the best smoothing coefficient, or could it be different for different applications? That's basically my question.
So our parameter is, what do you mean that it could be different for different applications?
So for example, if you apply it to a certain type of cell or a certain type of displacement field that you're looking for,
that parameter will have different values in each case. Yeah. Just it will only have the necessary values to make it mechanically consistent to fulfill that condition.
Yeah. Okay. Yeah. Thank you. Some questions from the audience. So may CCM depletion affect the material properties of the hydrogel?
So what's the question?
So if your CCM depletion would affect also the material properties of the hydrogels that you are studying, basically, that you are using?
In principle, not. It affects only the cell. It's a mutation of a specific gene of a cell. So the material properties, in principle, shouldn't be affected by that.
Okay. So yeah, another question about the ground truth. So the question states, so not sure about the way the ground truth was assessed. Can you please explain it a bit better?
Yeah, let me just go back to that slide. Here. Actually, the previous one. So we acquired this geometry of this, well, this is actually an angiogenic sprout, and we did a finite element meshing. And in Abaqus, we created, actually, this is a supplementary slide that I have here. You can see we created different cases of focal additions, let's say. And we varied focal addition size and what we call here focal addition density. So basically, we created, and actually focal additions are those areas where force is applied. And you can see here that we have applied force in, well, randomly distributed nodes of these protrusions of the cell, and there are many different cases. So these cases over here will create more smoother solutions, and these ones here more high frequency or more sparse solutions. And these are basically areas where force is applied. And then we apply those ground truth forces to, or tractions to those simulated bead images that you see here by simulating different beads and so on.
Great, thank you, Jorge. So I think that we need to stop here. There are a number of other questions that are asked from the audience, but as the time is limited, we can move on to the next speaker. Thanks a lot.
Thank you.
Thank you, Jorge. And so the next speaker is Sophie Rapagna. Her talk is cartilage thickness is correlated with the in vivo knee joint loading indices in osteoarthritic tibia.
Okay, so hi, my name is Sophie, and today I'll be talking to you about cartilage thickness as correlations with in vivo knee joint loading indices in osteoarthritic tibia. So osteoarthritis is a debilitating disease which most commonly affects the knee joint. And where towards later stages of the disease, the cartilage begins to degrade, the bone becomes sclerotic, leading to symptoms such as pain and loss of joint functionality. And it's a multifactorial disease with contributing risk factors such as age, genetics, sex, obesity, diet, bone metabolism, but also local mechanical factors such as joint mechanics and alignment. And the way that this ties in is that an abnormal loading or joint malalignment have been previously linked to altered medial to lateral distribution of loads upon the joint. And this is during habitual loading, so things like standing or walking, where, for example, in a neutral alignment, you can see that the mechanical axis passes from the center of the femoral head down to the center of the ankle joint, passing through the middle of the knee joint. But in a varus or a valgus alignment, there's this deviation between the knee joint and the mechanical axes. So in a varus alignment, this leads to higher medial condyle joint loads compared to lateral, which can then affect the bone mass distribution, the bone microarchitecture, and also the cartilage morphology. And it's a similar story for the knee adduction moment, where a greater knee adduction moment is linked to a higher medial to lateral loading ratio. But relationships between cartilage morphology and knee kinematics are conflicting. Reports of the role of the external rotation moment are underreported in the literature, and cartilage and the knee flexion moment in OA are conflicting. And part of this might be due to most measures of cartilage thickness being taken using MRI, which has a low spatial resolution. So that's an in-plane resolution of 150 to 300 micrometers and a slice thickness of 1 millimeter. So particularly in OA, where there are thinner regions of cartilage, the MRI might actually overestimate the cartilage thickness. So a high resolution imaging modality may actually be the key to addressing some of these issues, which leads to the aim of this study, which in end-stage knee OA subjects undergoing total knee replacement, I wanted to investigate relationships between cartilage thickness using high-resolution micro-CT of excised tibial plateaus with preoperative knee joint loading indices and joint alignment. To achieve this, I had a cohort of 25 end-stage knee OA patients where prior to surgery, their mechanical axis deviation was measured from plain radiographs. And also prior to surgery, subjects underwent gait analysis using 12 icon cameras and 4 forced platforms to collect kinematic and kinetic data. And using visual 3D, the moments were computed, being the knee adduction moment, the knee flexion moment and extension moment, the external and internal rotation moments. From here, the tibial plateaus were collected, stored in ethanol before being wrapped in cling wrap and micro-CT scans, with cross-sectional images reconstructed at 17 micrometers isotropic voxel size. So in comparison to micro-CT in MRI, this is 10 to 20 times higher resolution in terms of in-plane resolution, and it's 60 times greater in terms of slice thickness. And so from here, you can see the cartilage in the dark grey above and the bone underneath in the light grey. And from here, I segmented the cartilage using threshold values determined from grey level histograms over 5 specimens. I then created 3D representations where you can see the cartilage in blue and the bone underneath in white. And this shows a good correspondence to a photograph of the same tibial plateau, particularly in this area of denuded cartilage where you can see the bone coming through in both. And so the next stage was to create a thickness map where you can see in darker colours a thinner cartilage and in brighter colours a thicker cartilage. But for a quantitative assessment, I wanted to look at 4 cylindrical volumes of interest of 10 millimetres in diameter in the anterior medial, posterior medial, anterior lateral and posterior lateral regions. And these regions were selected based on a previous study by our group involving mapping of subchondral bone, where significant differences were found in these regions, being possible indicators of joint loading. And so the relationships between cartilage thickness, joint loading indices, and mechanical axis deviation were examined using Pearson's correlation analysis. And so by doing so, I could see a positive correlation in the anterior medial region between cartilage thickness and the knee adduction moment. Whereas laterally, there was a negative correlation in the lateral regions between cartilage thickness and the knee adduction moment. And given that a higher knee adduction moment is indicative of a higher medial load, this explains the thinner cartilage we see in the anterior medial region with a greater knee adduction moment. For the external rotation moment, there are positive correlations in the anterior medial region between cartilage thickness and the external rotation moment. Now, these correlations became stronger when I considered the medial to lateral cartilage thickness ratio and the external rotation moment. But now's a good time to remind you that I quantified cartilage using micro-CT. So, of course, we looked at the bone underneath. So in a previous study conducted by a group, we looked at the subchondral trabecular bone volume fraction underneath the cartilage in the same specimens and in the same regions. So where we saw the positive correlation between the medial to lateral cartilage thickness ratio and the external rotation moment, we see the inverse relationship between the medial to lateral subchondral trabecular bone volume fraction ratio and the external rotation moment. And as altered rotation mechanics are suggested to lead to shifts in the tibiofemoral contact regions, a reduction in the external rotation moment could indicate increased stress concentrations in the anterior medial or medial condyle. So this leads to the thinning and the wearing down of cartilage and a greater bone volume underneath in response to the increase in loading. And for the mechanical axis deviation, there was a negative correlation between the medial to lateral cartilage thickness ratio and the mechanical axis deviation, which is to be expected as the increase in mechanical axis deviation indicates a more varus alignment and a shift to more medial than lateral loading, which can be seen in these images here, where in a varus example, you've got the thinner cartilage medially compared to laterally, which is a lower medial to lateral ratio with a positive mechanical axis deviation or varus alignment. And it's the opposite for the valgus alignment, where now there's more cartilage medially than laterally, so a higher medial to lateral cartilage ratio with a valgus alignment. Correspondingly, in the underlying subchondral trabecular bone, we see the inverse relationship, where now we're in a varus alignment, there's thinner cartilage medially, there's now a higher amount of bone medially compared to laterally. And for a valgus alignment, or a negative mechanical axis deviation, where there's thinner cartilage laterally, there is now a greater amount of bone laterally compared to medially. So it's consistent with that whole joint response in OA compared due to altered loading. Now, a characteristic of the study is that I did not use any contrast agents. So a consequence of that is that I could not calculate or determine the glycoaminoglycans content. And this could be viewed as a limitation, but in my study, because I was concerned with cartilage thickness, instead I used a maximized signal to noise ratio. And a practical benefit of this is that it's less time intensive. And how well it corresponds to histology, I answered by performing a validation study where in 10 regions per 6 specimens, histology slices were prepared using safran and O and fast screen staining. And then through a systematic mapping, micro-CT slices could be systematically mapped to the histology slices. And so the average cartilage thickness per slice was measured and plotted, where we can see a strong linear relationship between the cartilage thickness using histology and micro-CT, with the coefficient of determination being 0.93. And so taken together, joint loading indices, particularly the knee adduction moment, external rotation moment, and mechanical axis deviation, were significantly correlated with regional cartilage thickness variation. And in particular, the medial to lateral cartilage thickness ratios were more strongly associated with external rotation moment and mechanical axis deviation. Cartilage thickness and the underlying trabecular bone volume fraction have inverse relationships with joint loading, which is consistent with what we know about OA morphology, being the response of a whole joint, and suggests a whole joint response to loading. So this could be important in gaining an insight into the understanding of knee OA and the improvement of targeted treatment options. I'd like to acknowledge the funding bodies and thank my co-authors, my supervisors, and you all for listening. Thank you.
Thank you very much, Sophie. Again, thanks for being also on time. So the paper is open for questions. While the audience write their questions, I start with one. I may have missed it during your methods, the description of your methods, but so is there any way of quantifying the potential effect of dehydration on the cartilage before you do the scan, and therefore you evaluate the cartilage thickness?
Yeah, so during our histology protocol, the specimens were rehydrated and then going through the series of dehydration, ethanol, and that whole process. So the effects that we saw, where there was a significant correlation between cartilage thickness and histology and micro-CT, makes me think that the effect of dehydration probably wasn't that big. Moreover, when we actually removed the specimens were wrapped in cling wrap. So when we actually removed the cling wrap after the scan, we could still see moisture on the tibial plateaus, which makes me think that they didn't undergo too much dehydration during the scanning process.
Okay, thank you. There's a question from the audience which states, I missed some reference data, so how can you be sure that the processes that you see are pathology driven? So basically you have a control group.
Oh, in terms of the control group, so unfortunately, because we did ex vivo scans, we could only really collect these from patients undergoing total knee replacement. But in terms of the literature, so the knee adduction moment, which we found to be greater in our studies, tends to be reported to be lower in controls in OA. The external rotation moment tends not to be reported too much, but in the one paper I found, it was supposedly larger in mild OA compared to our subjects which had severe OA. And in terms of mechanical axis deviation, that tends to be neutral, if not slightly varus. So our specimens differed quite a big deal compared to controls.
Okay, thank you. Another question from the audience, which is, so basically, what is the specific clinical impact of your results? So is it going to change the treatment options? So what is the impact that you can have clinically?
Okay, so there are quite a few possibilities. So there's the obvious one where maybe this could help lead into monitoring gait in vivo, and this could maybe be a possible early indicator of osteoarthritis. So the main goal of all this research is to try and understand the disease more so we can prevent the need for total knee replacement, because that's going to be the final treatment option. But anything we can do to prevent that is good. So whether this is starting to translate it into monitoring even the bone density in vivo or things like that to find these early indicators, or even performing clinical trials in terms of trying to see how various shoe insoles or orthotics can change based on the findings we found here with the external rotation moment and knee adduction moment.
All right, so thank you very much, Sophie, again. So I think that we can move to the last speaker.
Yeah.
Yeah, thank you, Sophie. So the fourth speaker of this session is Ehsan Soodmand, and the talk is about mechanically driven cellular self-organization as a mechanism driving large bone defect healing.
Great. Hello, everyone. Thank you very much, Luca, for the kind introduction. So bone is able to regenerate through a complex process. However, large bone defect result in delayed healing or non-union if they left untreated, as you can see in this tibial shaft bone defect. So to understand this clinical challenge, this matter has been investigated in vivo in rat, comparing a small and large bone defect. And these images show a mobile pantochrome stained longitudinal section of the osteotomy region 6 weeks after surgery. And as you can see, the yellow bony area deposited in a small bone defect bridged the gap area by connecting two cortices at both ends. However, in the large bone defect resulted in medullary cavity closure. So the question is why these non-union happen in the bone defect healing. To understand this and what drives the bone healing outcome in our research group, bone healing in large defect was investigated at an earlier time point, so 3 weeks post-surgery. And interestingly, it was observed that the organization of newly deposited collagen fiber during 3 weeks time point indicated here by yellow arrows is similar to the deposited bone structure at the later time point, which indicated here by black arrows. However, it still remains unknown what drives the collagen fiber organization. So our hypothesis is that during the earliest stage of healing, the mechanical signals drive the cellular organization and consequently the organization of collagen fibers, which lead to the bone healing outcome in the later time point. Therefore, the aim of this project is to understand how mechanical signals and geometrical constraints influence cellular organization during the earliest stage of bone defect healing. To do so, we designed a microtissue clamp in vitro setup that mimics the gap in a large bone defect by modifying a previously published setup. These clamps are used to mimic the geometrical constraint and to mount two collagen scaffolds at both ends of the gap as cell carriers. Human dermal fibroblasts are seeded in the collagen scaffold as a model cell that deposit the extracellular matrix. And to explore the earliest stage of bone defect healing, we used a fibrin gel biomaterial composed of thrombin and fibrinogen with a physiological combination, mimicking the mechanical environment of hematoma, which is formed right after the fracture. In addition, a spring wire provides resistance to the contraction of the fibrin gel. And this image is illustrating a prepared sample in a metal chamber for the cultivation. To further investigate the influence of mechanical signals locally surrounding the cells, we also developed an agent-based model coupled with fine entanglement analysis to simulate the mechanical regulation of cellular self-organization. This computer model replicates the conditions of the in vitro experiment, considering the geometry, boundary conditions, and also the material property. And it has two main components, the cells and the ECM. The cells are simulated as active force dipoles, and their orientation represents the orientation of the cells. And the cellular activities such as cellular migration, cellular reorientation, and proliferation are implemented in our agent-based model. In addition, the cells are able to apply traction forces and deform the surrounding matrix. And to investigate the role of mechanical signals on cellular organization, we simulated experimentally reported tendency of the cells to migrate toward a stiffer environment known as durotaxis. So using our in silico and in vitro systems, first we studied the cellular organization according to different initial positions. Therefore, configuration A is designed as a large gap with cells initially seated in the scaffold at the boundaries representing the large bone defect in vivo, where cells invade the gap from both ends, for example, the bone marrow and periosteum. And it was compared to configuration B, a large gap with cells initially seated homogeneously in the gap area as a control for configuration A, and also representing a situation of defect treated by cell implantation. And second, we investigated the cellular organization in a large versus a small gap by comparing configuration A with configuration C. Here is an exemplary histology image of the in vitro setup stained for F-actin, showing the cellular organization in the gap area after 14 days, which we use to perform our cellular orientation analysis. And this animation illustrates the cellular organization as a result of the computational modeling after 14 days, and different colors here indicating different cell orientations. We observed the cellular organization after 7 and 14 days, both in silico and in vitro, in two regions of interest, which are defined based on the in vivo observations, so the periphery region close to the boundaries and the middle of the gap. This polar plot illustrates that the cells in configuration A are oriented rather arbitrarily in the periphery region after 14 days. However, in configuration B, there are more aligned axially toward the other side of the gap. But interestingly, at the same time point in the middle of the gap, in both configurations, the cells are nicely aligned axially. So we could show that the initial spatial cell position influenced the cellular self-organization, and moreover, the cells are organized completely differently in the middle compared to the periphery region close to the boundaries. Furthermore, by comparing the cellular organization of 7 and 14 days post-feeding, we observed no considerable reorientation in the trend of cellular organization in both regions. Despite the fact that 14 days post-seeding, more cells meet each other from both ends in the middle of the gap, there was no change in the trend of cellular organization. Therefore, we can say that the cells reorient according to their initial configuration based on the mechanical environment they perceive initially and reorient accordingly. So in this slide, you can see the quantitative comparison of the in silico and in vitro results, and the solid bars represent the in silico and the hatch bar represent the in vitro result. So the in silico and in vitro results showing the same trend in cellular organization in both regions, the periphery and the middle as well. Therefore, we can conclude that the durotaxis phenomenon simulated in our computational model explains the cellular organization observed in our in vitro system. Moreover, the in silico model predicted a fast cellular organization in the axial direction in the small gap compared to the large gap. And as you can see here visually and quantitatively, the cells in periphery region are organized more axially in the small gap compared to the large gap. In the small gap, the distance between cells at both ends is short enough that the cells could mechanically sense the other end and reorient accordingly. However, this mechanical communication between two ends of the large gap was impaired. So far, we investigated the cellular organization in a simplified gap. Now let's look at the cell organization in an in vivo-like configuration. To do so, the computer model was modified to simulate the cortices as a geometrical constraints, and the cells invade the gap area from bone marrow and periosteum. And this simulation shows how our in vivo-like simulation works. Both after 7 and 14 days, we observed no dominant orientation for the cells in the periphery region, with even more inclination toward the lateral direction, as you can easily recognize here quantitatively and visually in the periphery region. However, if we look at the middle region, both after 7 and 14 days, the cells are nicely aligned axially. We observed that the cells were organized mostly laterally in front of the medullary cavity and cortices, and interestingly, this cellular organization in this region is similar to the organization of the collagen fibers, which was already observed in vivo. So to briefly summarize our findings, using the unique coupled in vitro and in silico system, we observed that the initial cell position influenced cellular self-organization in the large bone defect in vitro. Moreover, based on our in silico findings, durotaxis can explain the cellular self-organization observed in our in vitro large bone defect model. And by comparing the large and the small gap sizes, we found that the geometrical constraints and boundary conditions are playing an important role in the cellular self-organization, and they should be considered in the healing scenarios. Similar to the organization of the collagen fibers, observed in vivo, we also predicted that mechanically driven cellular self-organization result in the alignment of the cells to be perpendicular to the bridging direction at the gap ends. So for the future study, we are further developing the agent-based model to simulate the cell-mediated collagen fiber organization. And we are implementing a deposition, a reorientation, and a mineralization algorithm for the collagen fiber to be able to explain the cell-mediated collagen fibers organization in the earliest stage of bone defect healing. And this study will be done in collaboration with Professor Sandra Loraker at Eindhoven University of Technology. Thank you very much for your attention, and I would like to use this chance to thank all of my colleagues and supervisors who helped me to perform this study, and the foundation supports my project financially.
So thanks a lot, Ehsan, again for being on time and a nice presentation. I have already some questions from the audience. So the first question is, your model relies on imaging in a 2D plane, and the predictions are compared against these measurements. So would it be feasible to extend your model to be applied to movement in 3D? So not only 2D applications.
Yes. Yeah, so as you may understand the concept behind the study, so first we want to understand how the cells behave based on a very simplified model. So it's a 2D, so it's in vitro, it would be like a section that we make a section in 2D and we analyze the cellular orientation. And of course, when we understand how cells react to the boundary conditions and to the mechanical signals, we can further develop the model to the 3D and explain the whole scenarios in 3D.
Thank you, Ehsan. So next one is, so are the cellular activities, I guess, in the ABM model mutually independent? So basically proliferation does not depend by cellular organization, or does it?
No, it's not depend on so migration and reorientation is based on the durotaxis phenomena, but proliferation is not depending on the migration or anything else. So we extracted the proliferation factors based on the literature and we implemented into our agent-based model.
Right. I think it's time for another question. So did you include the metrics, or how did you model the mechanical signals?
So the matrix, yes, as I explained in the method. So the model has ECM as a matrix and also the cells. So I explained it here. I can show you briefly. So here, as you can see, the matrix is simulated as a matrix, and the cells are able to migrate over the nodes of that matrix, and then the interaction between them.
So and basically, so a follow-up question from the same participant is, so if it is based on a matrix, then can you basically use this model to optimize the design of some scaffolds in order to improve the cell alignment?
Yes, this kind of model exactly is using now in our system, in our research group, and they are using the same model to do the scaffold designing, the optimization of the scaffold, and then how also cells behave in the scaffold as well. So they are using it for that purpose as well now.
All right, good. Thank you very much, Ehsan. So I think that we are a bit late, but not so much considering the original delay for technical issues. So thanks a lot, Ehsan, and to all speakers. Luca, would you like to say anything?
Well, yeah, I would like to thank the 4 speakers. Very nice presentations. As you will know the winner tomorrow during the special announcements in the afternoon. So you can stay nervous all night, and tomorrow you will find out.